My background is as an anesthesiologist. I also have a fellowship in interventional pain management. I am board certified by the American Board of Anesthesiology, as well as fellowship trained and board certified in interventional pain management. Today what I want to do is just discuss overall treatment of migraines, and I want to discuss newer aspects. I'm going to go over conventional treatment, medication, just pathophysiology. I'm going to break it down in a little more patient ease. But then I want to discuss my role, how I view migraines. That's a little different than general medications or maybe even what you've had in the past. Just to start off, a little classification of migraines. This is the International Headache Society. If you ever researched medical terminology about migraines and headaches, there's many different classifications. There's many different medical codes for a migraine. And it can get complex, but this is the best summary, breaking it down into 3 parts. Primary headaches, secondary headaches, and then what they call cranial neuralgias. This is interesting, and I kind of want to focus a little bit about this. I believe the cranial neuralgias, facial pain, is a big part of migraines that's under-recognized and under-treated. But yet it's classified, according to the International Headache Society, as part of a migraine. I want to explain to you what, first of all, cranial neuralgias is and why it's classified as part of a migraine and what we can do to address this component. This is, and I'll explain, this is often underutilized and underaddressed component of migraines. Well, first of all, primary migraines, that was the first bullet. Primary migraine just refers to the disease entity in itself. What causes it? The cause of the migraine is what we believe is neurological. It's not from, we're not referring to stress, anxiety, or other confounding factors. What causes a migraine? Well, this slide tries to illustrate. Most of us believe that's vascular, the blood supply to the brain. From a background as an anesthesiologist, when someone's in the operating room, the most critical aspect is blood supply to the brain. The reason why is in the awake patient, there's a very tight autoregulation of blood supply to the brain. It is so tight, your blood pressure can go way up or way down. It will stay the same in the brain because this is a vital organ in our body and any fluctuation could be detriment. When a patient is under anesthesia, we inhibit the autoregulation. And so the brain does not have the ability. So that's why when you're under surgery, your anesthesiologist is focusing primarily on the blood supply to the brain because this can fluctuate because of the anesthetics. I remember as a resident and staff when I practiced anesthesia, we were doing these brain aneurysm cases or neurosurgical cases. We'd have special blood pressure monitors that were calibrated based upon, in part based upon gravity, but we would tape the calibration to the head. We did not care what the blood pressure was at chest level. It could fluctuate. That small of a incremental change in blood pressure to the head when you've inhibited autoregulation could be detrimental. So now going back to what causes a migraine, what does this have to do with the migraine? We believe that there's some sort of variation with the autoregulation in the brain. The capillaries have a slightly vasodilated tone, so normal fluid from the circulation gets out in the brain. That's that pounding, throbbing sensation. And a lot of your medications are designed to tighten up the blood vessels in the brain. Your triptans, even anti-inflammatory medications. We just slightly increase the tone, and it stops that throbbing, pounding sensation in the head. I'm going to talk about other medications, what we use and why we use them, but this slide illustrates something else that we're not familiar with, or a lot of people aren't familiar with. That's the trigeminal ganglion pathway. This is the brain stem right here. And this trigeminal nerve there's 12 cranial nerves. This one is the fifth one, and it sends sensation to our face. And we believe that this is a big part of migraines. That's why a migraine is more than just a headache. It is visual changes we call photophobia, ringing in the ears, visual auras, throbbing in the face. That's because this nerve provides sensation to the face, and somehow it is connected to this cycle with migraines. And it's actually, I believe, a feedback loop. It's almost like pouring gas on the fire. It really winds this up, the wind-up phenomenon. It starts with the blood vessels, and it triggers the trigeminal pathway, and it just winds up and becomes worse. Now, this is an old published study. I believe it's in 1944, Harvard Medical School. We found that with migraines, this is a EEG, where you're measuring brain activity in the brain. It's how you would diagnose a seizure. And they described, with this publication, what we call a cortical wave of electrical activity. Small little mini seizures in the brain are associated with migraines. So what does that mean? Well, that's probably why we use a lot of anticonvulsants for migraines. Lamictal, Topamax, gabapentin, a lot of these medications we incorporate to target this pathway of the migraine. So you've got the vascular system, blood vessels, the seizures, and then the trigeminal pathway, which I'll go into a little more detail in how we address that component. And this is just a picture describing what we call the cervical trigeminal pathway. I mentioned the fifth cranial nerve. There's three branches, one that goes to the forehead, the second to the nose, the cheek, and the third down to the jaw. Then you also have occipital nerves up at the upper part of the spinal cord. Now, these are small nerves, actually three of them. The third occipital nerve, greater occipital nerve, and lesser occipital nerve. These are sensory pathways to the back of the head, the neck, the scalp, some component to small little muscles in the back of the head, but again, referring to why is it this burning pain in the back of the head? Well, it starts here, the migraine, or here, and it triggers each of these areas because they're, sensitive to, they talk, it's crosstalk, in other words, the interneuron pathway. Now, I've addressed the first two. I've addressed the primary migraine, and then I'll skip down to the trigeminal pathway. And in the middle, I'm going to quickly go over this. What is a secondary migraine? Well, it's a headache caused by something else, stress, and more for those who treat. I don't know, does anyone here treat migraines? Or, okay. Well, just kind of from a clinical standpoint, as well from a patient standpoint, we want to look for other causes. We want to look for rheumatological, arthritis, or any sort of inflammation pathway. So we oftentimes draw a lot of labs. Different brain conditions, idiopathic intracranial hypertension, hypotension, a mass in the brain, an aneurysm. We want to treat the cause if there is a cause, an infection in the brain. So it's often difficult when you're seeing a patient with migraine. In the back of your head, is it something else I should look for, or is it keep treating it the way we've been treating it? And from a patient, it's very alarming when you have a really, really bad headache or your headache pattern has changed. What's going on with me? A lot of patients, I need an image of my brain. It's a severe pain, and you want to know if something's going on. And there's a way to decide whether the patient needs that or not, and it is reassuring to patient when, as a physician, when I tell the patient, I'm not going to order MRI for your headache because I'm going by this criteria, I don't reassure them. I don't think we need to. And just giving that patient that information is reassuring. Now, as far as lab work, we do just a basic panel, metabolic panel, thyroid panel, CBC, looking for potential infection, looking for lupus or any other rheumatological disorder. Older patients, throbbing headache on the side of their head, we call it temporal arteritis. It's usually an emergency. That causes blindness. It's just one of these zebras that we pound in medical school because it's the one in a million. If you ever come in contact with it, you need to recognize it and treat it. But it is a rare condition. And then hypercoagulable panel, we want to know if there's a stroke, multi-infarct dementia, small little mini strokes in the brain, so that's why we get imaging and blood work to see if the patient does have a issue that with the clotting factors. As far as imaging, now this is an acronym that we use to decide whether the patient needs an MRI or not. Systemic symptoms, fever, weight loss, it could be an infection, it could be cancer, sudden dramatic changes in their overall health. If the patient is immunocompromised, HIV or any other immunocompromised condition, cancer, if they've been on chemotherapy, could set them up for immunocompromise. I mean, you'd be surprised how many times a tuberculous disease or meningitis of the brain, something you never suspect in a normal person, however, because someone's immunocompromised, that could show up. You're looking for signs of strokes, and I'll tell patients, you know, if there's motor weakness, slurring of the speech, signs that would be indicative of a stroke, we want to look that up, make sure there's not an aneurysm or a bleed. We mentioned temporal arteritis, the first worst headache of the life, sudden onset, abrupt, a change in pattern from the previous headache history. So we're looking for something out of the ordinary, and most times we get images, even when we're following this logarithm. Most of them are negative, but I'd rather be safe than sorry if there is any of these signs or symptoms. And now, as far as pharmacological treatment, I'm going to briefly go over just treatment, a logarithm. How would we address when the patient uses medication, when you stop it? Migraines are difficult, and I always tell patients it's like throwing something on the wall and see what sticks. And that's so different than anything else we do in medicine. But with migraines, it's different. Patients can try 3 or 4 to 5 different anti-inflammatory medications until they find the one that works for them. And that's just very unusual compared to any other medical condition. So oftentimes patients keep throwing medicines at them, and then all of a sudden, wham, you find the one that works. To start off, Tylenol. Well, that's for mild pain. Why are you giving me this Tylenol? Well, I always tell patients keep that in the treatment because the rest of your medications, your anti-inflammatory medications, your triptans, even dihydroergotamine and some of the other medications, you can cause withdrawal headaches. There's only so many times you can use them before you start making the problem worse. Even opioids, the same thing. You have about 8 to 10 days per month that you can use them before you start developing withdrawal headaches. Tylenol is not one of them. I have not seen anything in literature saying that you can take Tylenol every day. As far as I found, I could be wrong, but never found an incidence of withdrawal headaches with Tylenol. Anti-inflammatory medications up to 10 days. It can be pretty frustrating. So first of all, try this. Second line, do the anti-inflammatory medications. It's probably a little less incidence of withdrawal headaches with NSAIDs. We like to use diclofenac. It's typically a stronger one. I was looking at some research, and they compared diclofenac with morphine. To my amazement, I think this is post-surgical pain, diclofenac, the higher doses, had a double-blind study. Patients didn't know what they're taking. Patients tend to prefer the diclofenac. So these anti-inflammatory medications are strong, and we should not underestimate them. And so you've tried the Tylenol, you've tried the anti-inflammatory. When is it time to use your triptans? Well, if you ever had a prescription for Imitrex or any of the other medications, you're going to get 9 per month. Well, I used to think, well, that's the insurance companies not wanting to pay so much because they're expensive. But you go back to looking at not more than 9 per month, you're going to make the problem worse. But, you know, so when you use it, that's just for the true migraine episode. I'll tell patients, pick your 9 worst headaches or migraines per month. But if they're starting to use more than that, then we have to look at other forms of control. We call it prophylactic control, which I'll get to in a minute. But, you know, triptans plus anti-inflammatory medications is okay. I'd rather not do it because we're, again, setting up the potential for withdrawal headaches, but this in combination, the triptans and ibuprofen taken together is better than any one alone. And this kind of summarizes that table of what I mentioned. Diclofenac's mentioned here for moderate to severe attacks, anti-inflammatories plus the triptans. Again, I got ahead of myself, but this just does describe the difficulty it is because one anti-inflammatory, one triptan, keep trying them until you find the one that works. Some other medications that I haven't mentioned. I want to talk about Migraine and Fioricet. Migraine is a little frustrating to me. It's taken off the market. In 2011, it was withdrawn, and I can't find a safety indication. I've done research, and it just appears that was a manufacturing protocol. The only company that did make it did not, I guess, follow some FDA procedure, and they shut them down, and I haven't heard of any plan to put it back on the market. So it appears to be a safe drug, unlike other drugs that are pulled from the market. It's a potential it could come back on the market, but I haven't. I started writing it, and a lot of my patients are saying that pharmacies don't have them. What this medication is, again, we believe it has something to do with regulating the blood pressure. They call it a sympathomimetic. It basically just stops your sympathetic drive, lowers your blood pressure. So again, same mechanism as the other triptans, or the reverse order. It increases the blood pressure and the tone. Fioricet. Now this is something. Another medication is a different mechanism of action than the triptans and the anti-inflammatory medications as far as effect on the blood pressure. However, it's not any better. When I first started training, I used to use Fioricet all the time. Oh, it's a different mechanism of action. It's not going to have the withdrawal. It's actually a lot worse. It's actually a barbiturate, of all things. I guess I have to speculate. It's, again, regulating the anticonvulsant pathway because, barbiturates or anesthetics, and anesthetics stop seizures. But it's actually worse than the triptans as far as withdrawal headaches. You can develop that within a few days. And withdrawal after taking them often can cause seizures, delirium tremens. This is something that you see an alcoholic go through after withdrawals, and it can be life-threatening. So something that needs to be carefully looked at. As far as the acute setting, this might be a little more geared towards a practitioner, but if you've ever spoke to anyone, a nurse, a doctor, anyone who's worked in the ER, it's frustrating to see someone coming in with migraines. You don't know who is, playing the pain medicine cord or not. However, these are other medications that are just as effective in the acute setting. Reglan, this is something that I can't even begin to speculate the mechanisms of action, but this is something we use for diabetic gastroparesis. We use it for nausea. How it has effect on migraines, I don't know, but it wouldn't be one I would. First of all, I don't know if it does come in PO form, but I haven't seen it used like that for a migraine. This is a higher dose. You actually have to give it with Benadryl to prevent weird movements, and this is called akathisia. It's something that's kind of alarming if you've ever seen it, but it's not life-threatening, but you have to use at a higher dose, and you have to give Benadryl to prevent it. So I don't think it would work in the PO form at the lower dose. Decadron, this is just a strong steroid medication. Just like the anti-inflammatory medication, has the same effect. Now this is interesting. Fluids, IV fluids. Well, if you think about it, you're looking at the circulation in the brain, the whole order regulation. Fluids we give for patients of low blood pressure, hypotension, and this kind of raises the arterial tone in the body. Now, I would disagree with this. I found this from the Massachusetts Handbook of Migraines. This is a half normal saline. Just going back from an anesthesiology background, I would probably put this in normal saline, a more concentrated dose. You want to pull the fluid back into circulation. In fact, when we have patients come in with a head trauma or even a neurosurgical procedure, the surgeon's open the head, inducing a lot of trauma. No matter how skilled hands he has, it's going to cause some trauma. With trauma, swelling, leak of fluids. So we give high concentrations of 3% normal saline or even mannitol to just concentrate it, basically a salt solution. You want to bring the fluid back in, prevent it from leaking out. So I would change this. I would just put normal saline, the concentrated dose. Magnesium sulfate is a good muscle relaxer. It could paralyze you in high enough doses. It could stop your heart in high enough doses. This is a relatively low dose. But at this dose, probably benign, but it has a good effect in aborting acute attacks of headaches. This is a strong dihydroergotamine. We would give this for women who had C-sections and couldn't stop bleeding. You can give it IM is the most common form or rectally, but it will raise your blood pressure. So this is strong stuff. I don't like to give this for patients with migraines, especially women of childbearing age. It is a category X drug. So, but this is, for refractory migraines, this does become a backup option. And a steroid dose pack, again, maybe speaking a little more to clinicians, prednisones or Decadron, methylprednisolone, it's common in the normal steroid dose pack. It's probably not as strong as these two. So if you are going to do office-based setting, let's say you go to the doctor, say the worst headache of my life, I just don't feel like it's not bad enough to go to the ER. Well, maybe a prednisone dose pack. They give you a methylprednisolone dose pack. It's probably not going to work. Either a Decadron or a prednisone dose pack. As far as chronic migraines are defined as a headache that lasts more than 4 hours, more than 15 days a month. And 15 days a month or more, you cannot keep using your triptans or you're going to make it worse. So what do? Well, that's when we start medications preventative. It's something you take, a preventative medication is something you take every day to prevent, not something you take whenever you do have a migraine. The only medication that's actually FDA approved for chronic migraines has become Botox. The tricky thing with the FDA, in order to get something approved, it doesn't mean it's better than anything else. It just means that this company had enough money to pay for the clinical trials to get it approved. But Topamax is something that's very common. Is actually anti-epileptic. So now we're going to the anti-seizure medications. I always like telling patients when I write a Topamax script. All right, I got to tell you about the side effects. At least a 5-pound weight loss. Give it to them, and you don't have to worry about compliance. They're taking that medication. This is a medication I use a lot. Elavil. It's again a different mechanism. It's Tricyclic Antidepressant. We don't use a lot. I don't know. Maybe psychiatrists use a lot for antidepressant. There's so many newer medications they've kind of fall out of favor, probably because there are side effects. But this side effect is one that I do like. It helps patients sleep. I remember one patient, the worst headaches, couldn't get it under control, seen everybody, and I just gave him some Elavil to help him sleep. And his headaches completely went away. It's just amazing. That is a story I hear often from other providers, but it's one of these, throw it up on the wall, see what it sticks, but it definitely is in the treatment logarithm for migraines. Looking at diet, different activity restrictions, kind of focus a little bit about diet. Tyramine, it's the aged food, pork, or just sausage, and things like that. It's a byproduct breakdown of a amino acid. It has some vasodilating properties, can make headaches worse. I can't tell you how many patients I talked to had worse headaches all their life. They went on this some organic weird diet and then went away. There's a list. I'll show you the list, but if you go to the website, it has a good list. Nitrates, just your cold cuts, hot dogs, aspartame and your artificial sweetener. MSG is your Asian food, your Chinese foods. National Headache Society has a good printout of foods that are allowed, foods you should take less of, and stuff you should absolutely avoid. I'd refer to this handout. It's actually a few pages long, but it would be good to look at. Other supplements, and there is some data that these herbal supplements do have an effect on headaches. They're just not well studied. No one's going to make any money off of it, but probably your daily multivitamin would have this. And then your lifestyle modifications. You can't do anything about the weather. Any married man can tell you can't do anything about the thermostat in your house. Other things you can modify: smoking, alcohol, the certain foods we've talked about. And there's something about menstruation headaches. Usually younger females get on a birth control medication. It levels out the estrogen, and we do know that estrogen fall around prior to menses does trigger headaches. And this is what I'm trying to spend most of my time talking about, these nerve blocks. I'll go over them each one at a time. Occipital nerve block I talked a little bit about earlier, but it is a very large nerve made up of the first three cervical cranial nerves. Spinal nerves. They're branches, and we often do occipital. There's various types of occipital nerve blocks. There's one that can be done in the office. I'll kind of talk about that. Again, it innervates the back of the scalp and small muscles in the back of the head. It usually doesn't have much of a motor effect. You can block both of them, and rarely do you even notice any head movement problems. But one of the mechanisms is that tightness in the muscles from stress back there. You block that nerve, and then it kind of relaxes those muscles, and the headaches do improve. This is a diagram of the occipital nerve. To kind of illustrate an injection in clinic, it's fairly easy to do. The problem with doing it is the scalp is so darn sensitive. You put a little bit of medication in there, I'll warn patients, like, this is going to hurt, this is going to hurt, this is going to hurt. And their headaches are so bad, they just let you do it anyway, and you do it, and then, my gosh, that hurts. But at least you tell them beforehand. They can't be too surprised. I've heard of people passing out just on the floor, but other doctors who haven't warned them. However, there's a procedure that I'll talk about I like to do in the x-ray, under sedation. That's a lot more comfortable. But this nerve course around these joints in the back of the neck, a lot of patients with arthritis or whiplash syndrome develop migraines from interruption of the atlanto-occipital joint, the C1-2 joint, C2-3 joint, atlanto-axis joint. So these are joints in the head that are often whiplash, hit pretty hard, any sort of trauma. And so you're damaging the tissue around here. It just happens to be the nerve that keeps telling you, hey, I'm injured. So you do x-ray, you do CT scans, their neck is clear, you just go do a nerve block or a nerve rhizotomy, and they get better. And this is just a little dissection, what a surgeon would see if he's going to the back of the head. You can see, I just wanted to illustrate that it does go around these joints. There are smaller branches. So you can do a block up here, and you still haven't covered these smaller branches. And so that's why sometimes you have to go do them under x-ray. This is another illustration of what the spine looks like. And this is just, again, those smaller branches coming off of this dorsal root ganglion and innervating the joints and the soft tissue around the spine. When I first came to Memorial, they wanted me to do an article just they just said, hey, pick a patient that you did a procedure on is doing better. And first thing that came to mind was this young girl here. She actually had a posterior decompression. This is all in the paper, so she had some sort of surgery, and just a lot of scar tissue back here, and so just a lot of occipital migraines. And so I went, did a nerve block, about 24 hours, complete pain relief, it came back. So I said, okay, we're gonna go do a nerve ablation. This is a radiofrequency needle. Went there under x-ray, a little sedation. This is where this is a big nerve root comes out. Spinal segment comes this way, and then you have the smaller branches course around here and back to the scalp and to the joints and soft tissue like I illustrated. So I went under x-ray and again numbed up this spot, turned the tip of that needle on to about 200 degrees Fahrenheit for 90 seconds, and we did a nerve ablation. Now the thing about radiofrequency, the beauty of this is that it's going to make a small lesion. We can control the heat, the pattern. We can do different testing to make sure it's in the right place under x-ray guidance too. So all these factors, safety really comes into play, but it's a safe procedure if it's done right. This is actually an occipital nerve stimulator. So this is another mechanism. You're not burning the nerve, you're not doing a nerve block, you're just putting these little leads and you're replacing the normal pain signals with other signals. You're overwhelming it with another type of signal. And I've seen patients have this, and they do extremely well. You go in there, test, usually a neurosurgeon or will go under the scalp under anesthesia, put these leads here. They're hanging out the back with a little portable battery for about 5-10 days. And if it completely takes away the headache, then he goes, has to implant them with this little battery. And this is a paper just reviewing. I think they took about 122 patients. They stuck the leads in. Half the group, they turned it on. The other half of the group, they didn't turn it on. And the group that they turned it on, about 50 to 70%, 50% or more said it was wonderful. 20% said it was pretty good. 70% got implanted and supposedly liked it and did well long term. Looking at, again, the lower part of the neck, I kind of talked about that upper C1, 2, 3 region. The IHS does classify cervicogenic headache, pain that's from the neck. You get a headache just from a lot of neck pain, in other words. It's called a secondary migraine. Okay, there's a cause for your migraine. It's just we got to treat the cause. Oftentimes I'll see patients for migraines, and it's mainly just evaluate the neck. See if it's not a secondary migraine, treat the neck. You look at MRI, you look at the disc bulging. Well, there's no significant disc pathology. But every time you push on this side of the neck, it hurts. You turn the neck to this side, it hurts, and there's just a lot of tenderness. And so you go, all right, you probably have some joint issues, facet arthropathy, and you go do these medial branch nerve blocks under x-ray, and it takes away the pain for 24 or 48 hours. It wears away, it comes back, then we go do the nerve ablation. It's pretty much how it works. So you're treating the cause of the headache. This is just a diagram of what facet joint pain really looks like. It can be very broad. It's hard to imagine, but a small little joint in your neck could project out and look like this. So that small little area causes a lot of havoc. Again, this is, like I mentioned, this is the nerve ablation. The needle's put right here. The small little nerve comes off of right here. It kind of courses around here. And so you're just putting a needle, just cutting it off and putting a little heat there, and you're doing nerve damage is what you're doing. But it's a very tiny, tiny nerve. Only job is sensory input. It's just stopping sensation. Well, patients say, well, don't I need that nerve? Yeah, your body needs that nerve to tell you have pain. I think you've got the message by now. We can turn that switch off. Again, now, cervical epidural steroid injections. I think this is good for certain types of migraines. It doesn't help every migraine, but occasionally I will see a patient with a C2-3 or a C3-4 disc bulge. Kind of uncommon in that region of the neck. You usually see it 6, 7, sometimes 5 and 6, but that's the majority of the area because that's the fulcrum of the neck where the most stress is at. A little rarer up C2-3. I've seen several times a 3 to 4 millimeter disc bulge, something that's not that large, but large enough to be noticed, oftentimes overlooked. What's the problem with the headache? Well, They said I had epidural steroid injections, it doesn't help. But then I'll go in with, I think, a little catheter, shove it all the way up the neck to the base of the skull, put the steroids there, and oh my gosh, it went away. The problem with the cervical epidural steroid injection, we normally go in at the lower part of the neck. Why? That's just the safest. It's the biggest area to go into. It's just many reasons it's the safest part of the neck. However, if I do want to get higher, there's two approaches. There's one from the side, and there's one with a little catheter. I'll kind of briefly explain the difference and why I like to use a catheter. This is kind of coming in from the side. We'll call it transforaminal. I did a lot of this in my training, and technically fairly easy to do, but there's some safety considerations. Occasionally I'll do it if a surgeon says, hey, do this nerve block. I want to see if they have pathology at C6 before I do surgery there, and you do it. That's a legitimate reason. But other than that, I think there's better ways, which are probably a little safer. This, hard to see, but I actually have a needle here. And I'm putting a low contrast dye. And normally it goes C6, 7. It goes up to C5 and 6, 2 or 3 levels, and that's where your medication stays. That's most of the time where the disc pathology is at, so it's a pretty good approach. If I want to get up high, this is actually, I have a needle here, and I tunnel this catheter way up here, and you see the contrast is coming up way at the top of the head. This is where I want to be. So instead of going through the side, I can avoid blood vessels, avoid the nerve roots, and just go the safest, easiest approach and get where I want to go. Now this is something else, a sphenopalatine nerve block. I have seen a lot more excitement about this procedure in the recent year or two. It's gaining a lot more popularity. It's not a new procedure, but we did quite a few of these in my training. I have some pictures, and it's fairly easy to do. The problem is you got a big blood vessel that comes across here. Well, I've actually seen, and have caused, sticking a needle through here, big cheek hematoma. It went away. The patient was very concerned, and it went away, but it's just more of an inconvenience, a nuance, but it is scary when your face is hanging down right here. So I always tell patients, if I do it, listen, this might occur, just want to let you know. But the patients I do it for, mainly the trigeminal neuralgists, they'll let you do anything. They're about to jump out a window, and that is actually described in medical literature. It can be a severe pain, and so they don't care. I mean, you stick a needle anywhere, but I typically like to avoid the invasive route if I can. If I do go the invasive route, this is a needle that I typically use for all my procedures, including this one. It's a blunt needle compared to the normal spinal needle. Okay, well, if I do have to come across a blood vessel, it usually just pushes it out of the way. It's a little more challenging, takes a little more finesse to get this needle in, but even when I go in the lumbar spine, I use this needle, because the last thing you need to do to a patient who's got an inflamed nerve root is go stick it with a needle that looks like that. You stick it with this thing, it'll move out of the way, they feel it, but it's not as traumatic. Little side port, if you do happen to be in the nerve, you're not going to put the medicine in the nerve. These are more expensive. These are actually very expensive, and it's not reimbursed by insurance for the needle, but I do believe it's safer, and I believe it's worthwhile using it. Even this is Dr. Gabor Rax. He actually invented this needle. He actually did a lot of research, and one of the founders, and why the field of interventional pain medicine is safe, is because of the work he and other colleagues have done. He developed this spinal needle, but he also did a lot of work in researching what type of steroid should be used where. Actually, a few months ago, the FDA, based upon his work and others, did make a statement against certain types of steroid injections in the neck, which we knew all along. If you did a fellowship training and are board certified, you knew that. But there's a lot of people out there who aren't board certified, who are doing these procedures, and they don't know. And so exposing patients to a lot of risks. So I would say if you do ever have an injection or anything, you want someone who's board certified and knows the benefits and risks. I do also have to say that I've been very pleased at this hospital. I work with a lot of different professionals, a lot of our orthopedic, I worked with a lot of colleagues. They're fellowship trained, they're primary board certified, and then they're fellowship trained. We've got a hand specialist, we've got a hip specialist, we've got a trauma specialist, and this is just ortho, and it goes on and on. We've got 2 neurosurgeons I work with. Everyone's not just board certified, they're board certified, fellowship trained, and double boarded. And so it really makes a big difference. I've actually got a new C-arm. I just went to the hospital and said, listen, I'm using these needles. They're safer. You're paying more money. Thank you very much. I want you to pay more money so I can get a new C-arm so I can get the angles I need to finesse this needle in. They bought it for me. So I've been very pleased with Memorial's, their support, and the staff I get to work with. This is just a picture of the transphenoidal sphenopalatine nerve block coming in through the side, putting some numbing medicine here. It's very good for cluster headaches. It's being found to be more effective for different types of migraines. A lot of patients, I'll talk to patients the other day. She uses her triptan every day. I said, you got to stop your triptan, but nothing else works. All the other prophylactic medications haven't helped. So oftentimes the patient like that, I'll go and I'll go this approach. This is actually just a catheter with in the nose, in the office, squirting some concentrated local anesthetic. And so you're going to do the same, achieve the same results, block this bundle of nerves here, stop that trigeminal pathway, interrupt it, along that course, and mitigate the facial pain and the migraines. It's great for clusters. We're still gathering a little more information about migraines, but anecdotally is found to be helpful for that as well. I mean, it's safe, effective, easy. And a lot of times I'll give patients, here's some blunt needles that I use to inject the back. Go squirt it up your nose if it helps. I'll give them a little script for compound pharmacy, 8% lidocaine, 1 cc, and kind of instruct them how to do it themselves. But the nasal mucosa is absorbing this medication and blocking that nerve bundle. This is just a different approach. Soak these with a concentrated lidocaine, put them in the back of the nose, let them lay back for about 10 minutes, just let it get absorbed to the nasal mucosa, and it's actually going through the skin and blocking that nerve bundle without having to go through the artery and the x-ray and the needles and all that. This is a recent article, relatively recent, 2006. They just described 8% of concentrated lidocaine mixture for patients with trigeminal neuralgia. I actually did this last week for a patient with trigeminal neuralgia. Came with the same symptoms, a shave is lightning, shocking across my face, and we did this, and last I heard, it seemed to do pretty well. Concerned the medicine wears off, so I'll probably, patient like that, I'll probably just give them some and teach them how to do them himself. This is actually an actual true trigeminal nerve block at the source, at the base of the head. It's what we did in our fellowship. We did several of these under CT guidance. Just kind of want to illustrate the invasive nature of a needle coming through the cheek all the way to the base of the skull. Remember our neuroradiologist from Argentina, he came out and said, the needle is in the base of the temporal lobe, pull it back a little bit. Like, oh gosh, pull it back, and the patient was fine. It's just amazing what the brain can handle. But it just kind of illustrates the risk of the procedure, invasive nature of this type of procedure, but for certain conditions. Now this patient, we're trying to see if it does mitigate their trigeminal neuralgia, they'll probably go on and have brain surgery or some decompression or gamma knife. So with risks, we're exposing the patient to this risk in order to hopefully save them from another risk. So it's always a balance. Something I wouldn't advocate just for normal headaches or any other less severe forms of trigeminal neuralgia. There's actually a 3D reconstruction we did. A small little opening, probably about the size of this needle. We've got it in the right spot and did 3D reconstruction. You can see the needle going here at the base of the skull. This is another illustration. Now, I like to, if I can, just do nerve blocks for the branches of the nerve. I don't have to get the whole trigeminal nerve. Maybe I can just get the nasociliary branch right there underneath the skin. And actually, there's a guy in fellowship, we did a Cryo Ablations. He had massive headache pain, this part of the head, and we had the only cryo machine left in this state or country as far as I know, but it just makes a little ice ball. The problem with making an ice ball is, you ever heard someone licking a telephone pole? in the cold, your tongue sticks to it. So you got to make sure you don't move your needle or you're going to pull off half of the scalp. That's probably why they don't manufacture them anymore, but they work very well. It's just we'd kind of make a small incision right here and right above his eyebrow, stick the cryo probe there, freeze it, hold it, hope you don't trip or anything, and let it thaw out, and then it freezes the nerve in ablation. This is why radiofrequency is more common, because you don't have the potential issues with cryoablation. But I mean, you can do a test nerve block. I mean, just right underneath the skin, here, different areas. For post-herpetic neuralgia in this distribution, it's oftentimes a very good block too. This is something I like the most. I like doing it. Patients get good results, and it avoids medications. If someone is using more triptans than they can, they're on their other medications, it's not helping, go in here, put Botox around the head, and I'll tell them the data. The data is 50% of patients get 50% or more pain or relief. It has to be a true migrainer, not just for headaches, not for tension headaches. Data is pretty clear. It's just for true migrainers. Again, defined as a migraine that lasts more than 4 hours, more than 15 days a month. It involves a lot of needles, okay? So the teeny, tiny 31 gauge needles, I tell patients it's like a mosquito bite. It kind of is. I kind of lie, but it kind of is. But you just go in there and just put a small amount of medication in these muscles, around the temporalis muscles, smaller muscles about here, occipital, parascapular, trapezius muscles. This is what we had. I worked with a neurology department in Shreveport, Deborah Elliott. She has a big migraine clinic, and we had access to these little models. We'd go stick the mannequins first before we'd stick patients, and it's actually kind of nice. I mean, it can be tricky where to go, but it was nice having this. All right. Thank y'all very much for coming.